Good evening, everyone. Thank you very much for joining. My name is Peter Friend. I'm a member of the Council of the Royal College of Surgeons of England, and I'm also the chair of the Research Committee. It's a great pleasure to be here for what is the second webinar to talk about the Royal College of Surgeons COVID Research Group. This was set up by my colleague, Professor Peter Hutchinson, in March of last year to bring together a wide range of research projects relating to the COVID pandemic. The first of these webinars was carried out in May last year, and this evening we have a small selection of the total portfolio of 50 projects which will be presented and which will be of, I'm sure, great interest. I'm very delighted that more than 120 people have already signed up for this evening's webinar, and that's covering a wide range of different ages, different expertise and specialties, and very much looking forward to the question and answer session at the end. I'm going to hand over now to Professor Peter Hutchinson, who, as I say, established this COVID research group a year ago. He is also the Director of Clinical Research at the Royal College of Surgeons. So over to you, Hutch.
Thanks very much, Peter. So welcome everybody to the second RCS COVID Research Group webinar. Thank you everybody for joining. Although Peter said I set it up, I was part of a team, Mura Akalak at the college, who was very much instrumental in getting us together, but also the amazing contribution we've had from all the group members in terms of what has been achieved over the last 12 months or so has been fantastic. What we're going to do is there are about 50 projects in the portfolio, so we're going to start with an overview and then we're just going to focus down on some of the more specific projects. I'm going to introduce the speakers sequentially, and we will reserve the questions and the discussion at the end that Professor Friend will chair. So without further ado, I'd like to welcome our first speaker, who's Dr. Felicity McIndale, who is going to talk about the research group outputs. Felicity is a plastic and cleft surgeon in Edinburgh and also leads a global cleft program, and she's not only contributed in terms of the COVID cleft work, but has actually been really helpful in bringing together the overall project portfolio. Felicity.
Thank you. Thank you very much, Hutch, and hello, everyone. Hutch has summarized the diverse involvement of all our surgical subspecialties in the group. And this project really focused on what we felt we had learned as a very diverse group from the COVID pandemic to make surgical research better. So next slide, please. As Hutch mentioned, there are over 50 projects from pretty much all the surgical subspecialties. We had weekly meetings to start off with, and now we have them monthly. And this is just a fraction of the many faces who've been involved in the various projects. So you'll hear about the individual projects, but we were really interested in, next slide please, what we could apply generally in the future. And so we sent out a questionnaire to all the PIs involved in the research group, the COVID research group, focusing on two main areas. One was the key findings of each of the individual projects, but then more broad observations on the entire research process, and focusing on four key areas. One was the key challenges that everyone faced setting things up in a pandemic, the lessons we learned and in overcoming those challenges, and particularly important research barriers, whether any had been removed or reduced, whether this made a difference in delivering the research more quickly, and the bit I'm really excited about, which is, should we continue this same approach beyond COVID? And again, everyone sharing their experiences about how we might make future surgical research practice better. So next slide, please. We sent this questionnaire out last summer. At the time, there were about 30 PIs and 29 returned their questionnaires. There are more projects than PIs because, or more projects than questionnaires because some returned a combined questionnaire for all their projects. The answers were free text, so I'll just summarize the themes that came back. Next slide, please. I'll summarize the key challenges and research barriers together because there's a lot of overlap. And a common comment was the challenge of setting things up really rapidly. I think all of us in the audience know the challenges of setting up a research project and how long it can take. So that had to be done a lot quicker. Also in the face of quite unpredictable service changes and redeployment. So again, that had to be done without much face-to-face contact, which was a challenge at first, but there was a flip side to it, which I'll talk about later. There was a lot of sensitivity and thoughtfulness around survey fatigue. I suspect many of you had lots of surveys, and I think it was a challenge to not overburden colleagues with too many surveys. And again, a lot of thoughtfulness around what is the right amount of data to collect, enough to be meaningful, but again, very conscious of not overburdening people at a time when we really didn't know what was hitting us. And I'll come back to the right amount of data again in relation to the next 2 points. Pretty much across the board, there were comments on the challenges of the regulatory and ethical paperwork and variations across centres in terms of A, the requirements, and B, the timelines to get that paperwork done. And interestingly, there was inconsistency in projects being defined as service evaluation or audit versus research, which obviously makes a huge difference in terms of the paperwork required. And people were trying to tread that tricky line between asking for just enough data to be meaningful, but not so much that it tipped into a research project with all the paperwork that entails. So those were some interesting challenges. Next slide, please. In terms of the lessons learned and things we might implement in future research, I've split it into things at an individual project level and things at a more strategic college or national level that maybe we could all think about. So at a practical, pragmatic project level, the value of established research or trainee collaborators and networks was undeniably huge. The novel ways of recruiting patients and centres using promotion from the RCS, charities and social media were very useful. Sharing registration documents to minimise duplication of research effort from one centre to another, and not surprisingly, teamworking, but critically teamworking beyond just medicine and beyond surgery with engineers, aerosol scientists, and that's something we hope will continue. We needed to be flexible around deadlines again because of the unpredictable processing of paperwork. Conventional methods of dissemination, such as journal publications, were too restrictive, with some journals turning things around quickly, others actually taking way too long. So people found other ways, such as engaging with public health bodies, government focus groups, and using preprints. Using online platforms for collaboration, for teaching and training made a big difference. Using research templates and automating processes in REDCap. And you'll hear more about that from James, particularly when you're managing huge, large author lists. But I'm not going to steal his thunder. He's got something interesting coming up for you. Next slide, please. And then at a more strategic level, I think there are 2 key messages. One was the hugely important role that the college played, Hutch in particular, in bringing all the subspecialties together. And personally, it was the first time in ever, actually, I had such enjoyable, stimulating interactions with people from specialties with whom I often don't interact. And we all learned from each other. The college helped in promoting recruitment. And again, a big shout out to Murat. Without his admin support, keeping us on track, I don't think the group would have functioned as well. And then I think a lot of focus on the importance of maximising research efficiency and what we can do better to minimise research waste and duplicated effort. And timelines vary, which they shouldn't for the same project. The speed with which Caldecott Guardians and different health boards approve things, whether they regard a project as research or service evaluation, seems to vary from centre to centre. And I think if we could all push for a unified national approach to some of these things, we could be more efficient and use our energies more productively. And I think one thing that we could maybe think about also is patient and public involvement. I think they do not understand how much time and effort is potentially wasted, and bringing them on board maybe makes a very worthwhile team to help learn from what we've seen in COVID and make surgical research better. Thank you.
Felicity, thank you very much for that really clear overview. So it's a pleasure now to introduce James Glazeby, who is an NHR Doctoral Research Fellow in Birmingham and has been one of the real drivers of the COVID research group. Over to you, James.
Thanks very much, Professor Hudson, Professor Friend, and Professor Mendale. What an amazing talk. It's really exciting to work as part of this group. And as you say, I hope there's a legacy as all collaborating together across specialities into the future. So I think a really exciting time for surgical research. I'm going to share with you in 5 minutes today a little bit about the journey of the COVID Surge Collaborative and the clinical questions we've sought to answer through international multi-center and prospective research on a really big scale. Next slide, please. So I think first to say this is obviously not my work, but actually the work of 15,000 or so collaborators around the world, with national representatives, national leads in each country, and just this huge global network and community really around this project, all united by the desire to improve surgical safety and capacity and understanding for our patients in this time of the pandemic. So a huge thanks to all our collaborators for their involvement in this network. Next slide, please. And it'd be remiss not to mention our wonderful funders right at the start, who were able to support this project right at the very earliest stages of the pandemic, when they themselves were under lots of financial pressure. So without them, it wouldn't have been possible. So huge thanks to them too. Next slide, please. So we really started with this journey trying to anticipate what the impact was on surgical cancellations around the world. And in our sort of first modelling study published in the BJS, we estimated there was sort of about 30 million operations cancelled in the first 3 months of the pandemic. And we've heard quite a few sort of numbers bashed around the media recently, but this is likely to be significantly larger now. And perhaps was sort of one of the first papers to put forward this idea of this huge upswell in surgical capacity, which was going to have to be filled in the future. Next slide, please. So alongside that kind of cancellations of operations, there's this question: is it safe to continue surgery? So our very earliest study was just 1,000 patients, but published within a month or so of the start of the pandemic. And it was this urgent response to find out whether it was safe to operate on patients with perioperative SARS-CoV-2 infection. And this data published in the Lancet showed that there was this really substantial risk of pulmonary complications and death for patients with an infection in the 7 days before surgery or up to 30 days after surgery. And so I'd suggest this was hypothesis generating and had lots of caveats at the time around testing and things like that. But I think it put forward for the first time in writing that there was this element of safety which we could be concerned about for our patients. Next slide, please. So not to pose problems and then not be able to do anything about them, we sought in our sort of second study, COVID Surge Cancer, to ask what can we do to protect our patients from perioperative infection. And our first paper from this study examined the role of COVID-19 free surgical pathways, or you might know them as cold sites or green sites, where patients undergoing elective surgery were protected from areas where COVID-19 patients were treated. Surprisingly, at this stage of the study, there was only 30% of patients being operated in these pathways. So it really was a kind of critical issue, patients being mixed in with patients with COVID-19. And we demonstrated that across lots of different subgroups and sensitivity analyses, there was always this benefit of providing COVID-19 free pathways, whether there was major surgery or minor surgery, whether there was a very high rate of COVID-19 in the population or a lower rate. So we think this is really one of the kind of grounding philosophies that can protect patients undergoing elective surgery until universal vaccination coverage is available. Next slide, please. So hand in hand with that, of course, comes testing for patients. And in the early part of the pandemic, if you remember, people were doing kind of clinical screening questionnaires and CT testing, and some patients were getting swab testing. And we demonstrated in the data that patients that had a PCR test and nasal pharyngeal swab were significantly less likely to get post-operative pulmonary complications after surgery. And we hypothesized this was by identifying patients with asymptomatic infection and then delaying their surgery for a later date, so they didn't have that asymptomatic or pre-symptomatic carriage into the perioperative period. And the results of that were different for different types of surgery again. So for major surgery in a high-risk area, 1 in 20 patients, for every one test you would do, you'd save one pulmonary complication for every 18 tests that were done, whereas minor surgery in a low-risk area, perhaps a little bit less benefit. But some important data to support the implementation of testing globally. Next slide, please. Alongside this, we've been working with our HCR UK, which is an AI and sort of machine learning network around the UK. And we've been trying to work out which patients were perhaps at higher risk of mortality and severe complications after perioperative infection. We felt this sort of went hand in hand with the COVID-19 free pathways work, because if you can choose the right patients and maximize safety, that really will sort of decrease the overall burden of death to these patients. So this data is going to be released soon and will allow surgeons on the front line to risk stratify patients to decide whether or not it's safe to continue with their elective surgery or perhaps delay for a later stage in really high risk areas. Next slide, please. So this takes us on to sort of the second half, and really this was another question that was sort of knocking around the surgical community. For patients that have an infection, be that symptomatic, asymptomatic with a swab positive, how long should we delay surgery for? And we only had a very tiny subgroup of patients in our first study, 122 patients, where there was this sort of delay to surgery after a positive swab. But that did give this early signal that there was an issue with safety after delay to, if you operated on people too soon after a positive nasal swab. So we joined together two global collaborative networks, the Global Surge Collaborative and the COVID Surge Collaborative, to really address this question in a global sense. And we delivered a study across 116 countries in 100,000 patients to answer this question robustly. Next slide, please. And this was the data. So we published it just a couple of months after completing the study and locking the database, which I think alludes to what Professor Merndale suggested about this rapid pathway needed for publications of this data. And we found in this paper in particular, working with the journal right from the start to set timelines and expectations was really, really important. And this showed that for patients that had a positive swab and then were delayed for over 7 weeks, there was sort of this return to the baseline rate of post-operative death. But before that, there was this potential risk of safety. And for patients that were still symptomatic 7 weeks after their initial infection, and then with this benefit probably of delaying them a little longer. So some really important data to guide our decision-making for elective surgery. Next slide, please. And so the final thing which has been released from our group at the moment was looking at vaccination. And again, to show like these kind of novel partnerships that have evolved with the pandemic, the college here worked with the Joint Committee on Vaccination in the government to really try and drive this data into practice. And we showed that if you took a patient from that was planned for elective surgery and compared them to sort of an age-matched group of the general population, then you would save a number of additional lives by prioritizing surgical patients ahead of members of the general population of a similar age. So some really compelling information to suggest that we should plan to vaccinate our patients before they undergo elective surgery. In the UK, things are flying by, but in some countries where it's been more difficult to impose universal vaccination, and this is really important data. Next slide, please. So just to finish, maybe just an idea of the impact of this work. So as I understand, there's been the work from COVID Surge has been reported in over 900 newspapers, news channels around the world, including the largest English language circulation newspaper, the Times of India, and featured in The Economist and Forbes magazine. Next slide, please. And excitingly, we think our latest study, the Surge Week study, may actually be the largest scientific collaboration ever undertaken, with 15,000 authors, collaborating co-authors that contributed to this project and are recognized, PubMed citable on this data set. And we think that's sort of about 3 times bigger than the previous record holder, which is the Large Hadron Collider in Switzerland. So hot off the press, we submitted our request for this record, and they're looking into it. So hopefully we'll be able to share some news about this soon. But I think a recognition of how the surgical communities pulled together to answer these crucial questions for patients. Next slide, please. How have we worked to get the data out to patients? Well, we've worked with a patient advisory group from Bowel Research UK, who have been incredible. One of our colleagues, Mary Venn, has been absolutely instrumental in this and has published this in the BMJ, this model of deep collaboration. But effectively produced videos and resources translated into a number of all the sort of major languages around the world, which can be given to patients at the time of their operative planning, which we thought was really important. And it's a great work from the patient group. And final slide, please. And we've been looking to different methods of trying to get this out to policymakers. So we've been producing these kind of high fidelity overview documents, which can be sent to your hospital managers, to governments and officials in different countries, to give them an overview of this data and help surgeons implement change in practice. Final slides, please. And for surgeons themselves, again, this is hot off the press, but we've been working on a digital resource which would be CME accredited, free to access, which will allow surgeons to run through this data in detail, look at multimedia resources around the lessons learned, and critique themselves whether they're to believe the data, strengths and weaknesses. But hopefully this will be a way which we can kind of share this with the world and try and let as many people as we know as possible know about the lessons that we've learned. So a huge thanks again to the college for inviting me to talk today, and a massive credit to our whole collaborating network for all of this work. Thank you very much.
James, absolutely fantastic, both in terms of the academic output, but in providing this absolutely critical information that's really guiding us through this really difficult pandemic. So thank you. Our next speaker is Jasmine Winter-Beatty. Jasmine's a colorectal trainee and a clinical research fellow at Imperial, and she's going to talk about the PanSurge Collaborative. Thank you.
Hello, thank you very much for having me. It's been a pleasure to work with the rest of the research, COVID research group at the Royal College, and I'm just going to tell you a little bit about the work that we have done within PanSurge. All of this, of course, is a result of the joint efforts of the whole of the PanSurge team that was just there. And these are just a few of my colleagues. There's many, many more collaborators that contributed from around the world, and to whom we're really grateful. And of course, the reason we came together, next slide, please, was our shared objective to try and support the COVID-19 response. And we soon realized that we didn't have a great understanding of the threat we were facing, but also that what little information was coming across was often unreliable, and through it was just coming through in drips and drabs, really. So we needed to study the virus, and also try to improve the channels of communication so that we could get better access to the information coming up across the world. So to do that, we decided to set up a digital knowledge sharing platform, and we organized 32 webinars that are visible on our YouTube channel. And at the beginning, these were actually just conversations with our colleagues on the front line in Milan, for example, trying to just gather insights about what they were facing, And these were really important and changed clinical practice where we worked when we heard for the first time about the risks of thromboembolic disease, for example, that they were seeing in their severe patients. And we still didn't have any news about that. And it's important to highlight that had we waited for the normal channels of communication, we probably wouldn't have heard about it for a few more months down the line. So there was definitely a need to speed up and help coordinate all of our efforts globally. But also we realized that in studying the threat we faced, we needed to redesign research paradigms and try and adopt more agile and responsive, adaptive research strategies. And in doing so, it was also essential that we utilized new technologies and found more creative approaches to the issue. So next slide, please. Amongst the other the studies that we conducted, PREDICT was probably our most ambitious. Now, it obviously pales in comparison to COVID surge, which is a hard act to follow. But our intent when we set out was to try and identify factors that would help frontline staff predict the outcomes for surgical patients presenting with COVID-19, but also to try and understand factors that might affect all surgical patients, irrespective of COVID-19, as a result of the collateral indirect effects of the pandemic. So to do that, we set out to collect hypergranular patient data and at the same time concomitant data about surgical resources, so including surgical staffing levels and restructuring within these participating centres. Here I have just got a snapshot of the results from the emergency patient subgroup, which we are hoping will be published soon. And in alignment with other large cohort studies, we did have within our group of 3,100 patients higher mortality rates for COVID positive patients. We do have to remember, however, that the pickup rate of COVID was very low at the beginning. In fact, within our cohort, only 14% of patients were being screened on admission in March versus 76% by July, which of course suggests that there's probably some bias, and probably the sickest, most critically unwell patients were the ones being tested. And of course, we also need to look at those patients who presented with the surgical pathology as a consequence of COVID disease, such as, again, thromboembolic events that we found out about later on, as opposed to patients who were coming in with surgical pathology as a primary presentation and were coincidentally found to have COVID. But our overall mortality was 3.6%, 15.5% for COVID positive patients. And in our regression analysis, it was not associated to surgical intervention alone. Interestingly, we did find that the best predictors of poor outcomes, so in hospital mortality and length of stay, were higher clinical frailty scores and higher Charlson comorbidity indexes. And the clinical frailty scale in particular aligns also with the COPE study by Elliott et al. That was published last year. So we do feel that that would probably be a very good tool to add in risk stratifications of patients. We also did find that the patients presenting in the period of March, April, May, so in the real peak of the first wave, were also were independently associated. Those periods were independently associated with increased in-hospital mortality, as you can see down there. Sorry, next slide, please. If we look at surgical services, sorry, you skipped one. Can you go back to the slide just before? Thank you. This is a snapshot of the UK surgical services, and as you can see, there was significant drastic changes in surgical resources. On the right, you can see the level of staffing in the centres within the UK. At the top, that's staffing levels pre-pandemic, and at the bottom, that's during the pandemic. And as you can see, the more darker part of the bar charts have almost completely disappeared, and the same centres are directly aligned. And this corresponds with the most junior doctors who, as we know, were the ones that were redeployed. And on average, 27% of the teams were redeployed, ranging between 10 and 60%. On the left side, you can see instead on the top the numbers of operating theatres, and at the bottom the number of intensive care beds. Sorry, it is a little bit small. The blue bar charts are pre-COVID levels and the red are during COVID. So you can see the operating theatres were almost decimated. The red charts are much, much smaller. It's very obvious. And we found that there was an average decrease of 63% in operating theatres. And you can see the inverse is visible, the inverse trend for intensive care beds. There's a lot more data to come from the PREDICT study. Just today, the endocrine results were published, which also showed significant change in surgical practices. And hopefully the whole thing will be published soon. Could we move to the next slide, please? And these are just two other studies that I chose because I think as we prepare to face the resumption of services, these remind us of the task we face. On the left, we have Comms UK, which was a survey of bariatric national services. Again, I'm sorry it's very small, but you can just about make out at the top that 67% of the bariatric centres we surveyed were having no MDT activity within the month of April last year, and the 97.7% of the centres performed 0 elective bariatric surgery. So there was definitely a massive cessation of these elective services, which would not have helped the obesity phenomenon. On the right, we have ColoQ, which is instead a global survey of colorectal practice, which recruited 191 surgeons in 156 hospitals. And this was a really interesting study that correlated bed capacity with COVID-19 burden to try and give us a quantification of the stress that these centres were under. And you can see on this top left diagram, the areas in red are obviously those with facing the highest stress levels. And across all centres, we found that there was significant decrease in diagnostic and therapeutic interventions for colorectal cancer. Endoscopic strategies were completely stopped in 20% of centres. Similarly, 20% of centres had a complete cessation of endoluminal treatment for early colorectal cancers. 40% of MRIs, CTs, and 70% of diagnostic endoscopy centres also reported reduction in these services. And in terms of surgical management, 7% of centres had no surgical resections happening at all. 29% abandoned laparoscopic techniques, which we know was probably associated with the earlier worries about aerosol generation. And a lot of centres also found increased chemoradiotherapy treatment, especially for patients that were facing delays or where there was cessation of resections. And half of centres reported an increase in stroma formation. Sorry, that's a lot of data, but it just really wanted to highlight how much this has affected surgical performance and management of our patients. And interestingly, in a lot of, there's so much variation that we can see that there was some guidance was missing. And unfortunately, in some of the centres, the extent of the change does not correlate with the amount of stress that those centres were under. Next slide, please. And this is I just wanted to leave you with this. Sorry, you've gone one too far. This is our SAFE study, which was a survey looking at the mental well-being of healthcare staff across 3 countries, Poland, UK and Singapore, and almost 3,600 participants responded. And as you can see, these results are quite alarming. 67% of the participants screened positive for burnout. 10% were also positive for signs of depression, and 20% for anxiety. And these are really staggering numbers, and this was only after the first wave. So I dread to imagine what it would be like after the second and third wave, that certainly in London was even worse. And I just wanted to highlight this, because when we confront the huge backlog, possible complications from suboptimal treatment and delayed presentations that we have seen and we know of from our studies in COVID surge and lots of other work, we need to remember that the people we depend to face all of this is our workforce, and that they are exhausted. So this is certainly another lesson for us to learn for the future, amongst, however, lots of other important lessons. Hopefully we will see some change in research paradigms, as Felicity mentioned, and more networking and collaboration. And I'm sorry I can't show you the rest of our work, but it's all on our website if you wanted to have a look. That's it. Thank you very much.
Jasmine, thank you. Fantastic. Really, really important data showing the impact on services, and some really important issues that you highlighted there about the healthcare professionals, and people are exhausted, and how we're going to deal with that too. So moving rapidly on, Dr. Daisy Elliott is a research fellow in Bristol, and Daisy's done some qualitative research on the impact of COVID-19. Daisy.
Thank you, and thank you for having me. It's been really wonderful seeing the presentations and hearing about all of the different wonderful COVID projects happening. So today I'm going to give you a very brief overview then of the Lotus D19 study, and this is quite different to the other studies that have been described so far. This is a qualitative study. So if you can move to the next slide, please. Thank you. So just to provide a bit of background, we obviously know that COVID presents new risks in surgery. And of course, there is an abundance of guidelines about how to mitigate this risk. And these are constantly evolving and are based upon the most available evidence, as well as expert opinion. But qualitative research provides a real opportunity to gain in-depth insights into what is actually happening on the front line. And in addition to that, it gives an opportunity to understand private concerns and fears and worries. And so we interviewed 43 healthcare professionals, and we spoke to a range of people in different roles, so surgeons from different specialties, anaesthetists, and those in nursing roles. We were mindful as well that we wanted to understand how perspectives differed in the different countries. So we spoke to people in the UK, as well as countries such as Italy, Spain, China, and New Zealand. And what this gave us is a real opportunity to understand perspectives of the pandemic in real time. So when we started interviews all the way back in April last year, which feels like a lifetime ago, we were talking to people in the UK, and there was such a sense of anxiety and apprehension about what was coming. They likened it to waiting for a tsunami to hit after seeing everything that was happening in other countries. We spoke to people in Italy, and they were completely and utterly in the thick of it. They were exhausted and they were drained from everything that had happened, and they likened it to being in a war. So we were really able to capture these experiences as people were enduring this. So if you can move to the next slide, please. So our first paper looked at how healthcare professionals perceived risks in surgery, and also what they did to mitigate these risks. And we found that guidelines were not a panacea. In fact, quite the opposite. A lot of people found them really quite confusing or vague or contradictory. And when we spoke to people about what they were actually doing in practice, it was very clear that the entire context of surgery had changed. They described on an organisational level tremendous changes to the pathway, where entire pathways had changed. They described what was happening in the theatre had fundamentally differed with different innovations and strategies and modifications. So for instance, one ophthalmologist we spoke to described how when they were removing eyes, they were now using local anaesthetic rather than general anaesthetic to avoid intubating patients. And another thing that we find very consistently across patients, participants, is that because they were donning this increased level of PPE, they were finding it really very hard to communicate in theatre with their colleagues. And so they had to identify different strategies that enabled them to communicate so that patient care wasn't compromised. I think the thing that we took from this was that teamwork and communication was absolutely crucial in how the various teams adapted. But amongst all of this, there was so little evidence to guide participants. They really were learning as they were going, and they found that incredibly unsettling, and they were very uncertain about what was optimal practice in this context. Another key finding was that we found a real tension between what was best for patients and what was best for healthcare professionals, as stated by the guidance. So a real contentious issue at the time was laparoscopic surgery, where a lot of the guidance said it simply must not be done, it should be open instead. And the surgeons that we spoke to felt really conflicted about this because they felt that laparoscopic surgery was better for the patients. So I think this is an example of how decision-making during the pandemic was actually incredibly difficult and complex as well. So if you can move to the next slide. So I think Lotus C19 was really important because it gave us insights into how teams were adapting and modifying their practices. I think in terms of what's next, well, Lotus C19 was very much just a snapshot, and I think that qualitative research can and should be used to understand how teams are continuing to adapt in the later stages of the pandemic. Although it wasn't an objective of our research, it was very clear that when we spoke to people that the pandemic had had a huge psychological and physical impact, and I think Jasmine spoke about this wonderfully, and I think taken together it really highlights the need to develop interventions to support people to deal with the aftermath of everything that has happened. And I guess fundamentally as well, there is a need to consider how surgery is going to look in a post-COVID world. So some other qualitative research that is going on within our team, led by Dr. Leila Bushnoz, the Consider C19 study, is looking at how decisions are made about which patients should now undergo surgery, and then how these decisions are communicated with patients. So that's it for me for now. Thank you very much for listening. And the final thing I want to say is thank you to all of the people that were involved in this study, because it really was a tremendous team effort.
Daisy, thank you. Really, really important again, and really nice qualitative research. So great effort, well done. So moving rapidly on, Martin Birchall is Professor of Laryngology, and he's Director of the NIHR Incubator for Surgery and Surgical Technologies. Martin.
Yeah, thank you, Hutch. Can you hear me okay?
Perfect, thank you.
Good. No, so I actually, I'm in complete awe in response to the presentations before mine, and what amazing research, how the communities come together. It's just astonishing. So the NHR Incubator is actually funded last year, and its intent is to increase the number of the whole theatre team who are ready for research, basically. It's to overcome barriers to research career progression in the whole theatre team. But it serendipitously represented a multidisciplinary group of individuals and engineers at the time of the crisis. And it was inevitable that some ideas in relation to crisis might be thrown out. And there were quite a number of these that were done by the individual centres, not least of which was Daisy's study that we just heard, but also ones in Leeds, Cambridge, Oxford and elsewhere. So what I want to talk about today is communication though. One of the things that Lotus demonstrated was consistently theatre staff were finding it extremely difficult to talk through PPE. So some of the things that I'm borrowing from Daisy's study People have said fundamentally communication is very difficult. We're not allowed to walk in and out of theatre. Somebody said, I brought some walkie-talkies, which are quite good. One team was using a system called Vocera, which is borrowed from MGH. There was a team that said, we got some whiteboards donated to help us communicate. We were writing on the inside of the operating theatre and holding it up to the window so that the runner could see what we wanted. And then on one occasion, one of the anaesthetists had the idea of bringing some Bluetooth speakers in. So people universally across the world were aware of this major communication issue and coming up with a variety of solutions. Well, we thought we'd look into just how big a problem is this quantitatively, and also what solutions could we come up with that would be reasonably cost effective. So next slide, please. Thank you very much. So next point. So what we did was we simply accessed off-the-shelf equipment to start with, and our first ideas were around using Bluetooth equipment based on the internet, and we rapidly found that this was inadequate. Such equipment relies on your hospital having a totally reliable internet service, and few of us, sadly, in this day and age have that, let alone internationally. Also, relying on the internet means you introduce a delay. So if you are closer than about 4 meters away, you get an untenable echo, and it just becomes impossible. So in myself and my assistant operating on the same patient, you really couldn't communicate effectively using Bluetooth technology. So we moved on to trying radio tech and tried a variety of systems. Initially, we tried a system that had been used for emergency recovery. And what we found there was that was great. These are systems that are widely used in the military, in the police, rescue services, emergency relief. They were a substantial improvement, but they are voice activated, and you have to have a certain volume of voice to trigger it. And everybody is connected at the same time. So there's a babble effect as well. As you start speaking, it cuts off your first syllable as well. So unless you have a very clear communication protocol, most of the radio systems don't communicate everything you need to know. And where you're communicating an emergency in 2 words with 4 syllables, it's pretty critical to make sure you get that right. We moved into our simulated operating theatre at UCH, and being part of an ENT hospital, we leaned on our audiologists. Andy Hall is an otologist who trained with us and was working at GOS, now in Cardiff, and Wayne Ellis, who's head of audiology. And what they did was they simulated the normal amounts of sound that you get in an operating theatre with and without PPE. And this is being written up and it's being considered by BJA. Revisions been submitted at the moment. Essentially, what we found is that, I mean, normally in an operating theatre, you will have something like anywhere between 30 and 50 decibel ambient noise with beeping, chatter, equipment moving around. I'm speaking at around 30 decibels at the moment. At 50 decibels, you start to miss things, without a doubt. If you add in theatre music, that adds another 15 to 20 decibels. And once you get up to 70, you introduce very significant surgical and theatre team errors. If you actually introduce power tools, it gets up to anywhere between 100 and 120, which is the equivalent of a plane taking off at 30 yards. We found that adding PPE, one level of PPE, was equivalent to adding the music. So if you just wore a mask, you'd take it up to around 80. But as soon as you added a visor as well, it exponentially increased the problems. And speech recognition scores dropped by 90%. This basically means that if you're wearing a full set of PPE, you have to be standing right next to somebody and shouting in order to be properly heard, or using some form of hand gestures, or the whiteboards that they were using in the study we just showed. It is really, really significant. And this does matter. Studies have shown that if you can't hear people, you do make communication errors. Next point, please. And the next one, please. Felicity mentioned how research during COVID was done as swiftly as was reasonably possible. We consulted with our local ethics teams, and they agreed that this was service improvement and issued a letter in support of that. So we did go down that line as well. What we found was there's no single off-the-shelf perfect technology with all the pluses and minuses that we were looking for. We then launched a Delphi study to try and find out what were the main criteria you'd want in an ideal set of equipment. This has now been through 2 Delphi iterations and is presently about to enter its 3rd. This was also done with the magnificent surgical and qualitative research unit in Bristol, and particularly with Natalie Blencoe and colleagues there, Jane Blaisby. So that we will be reporting on that very soon. Next point, please. What we've, I mean, the high levels are that you know, safety is foremost, but there are also issues around comfort, cost, access, cleaning, etc. Next point. Okay, next slide. Okay, fine. So that's almost where we're up to, except that we now do have a prototype that actually does tick a lot of the boxes. I'm actually wearing a dongle at the moment, and this is the entire kit that everybody would wear. It's around 20 grams. Most of the radio equipment is much heavier than this and bulky, and has buttons that you have to press on and off. This is easy to press on and off. It communicates via Bluetooth with a base set, which is set up separately. Importantly, this also has subgroups, so that not everybody needs to communicate at the same time. You can toggle between subgroups, an anaesthetic one, a surgical and scrubs subgroup. But in the case of the startup, the team brief, and the debrief, you can join up all together, and you can also join up together for emergencies as well. There's no cutouts. It's on the whole time, and the audio quality is much better. So we're now we've found a manufacturer who are able to produce this. We're going to be trialing this in different settings. In order to introduce new kits, you have to think of quite a lot of things, and so we're now working to look at our procurement side. Our trust runs a risk workshop for all new equipment coming in. Infection control is clearly critical. Fit testing still remains important. So this has a boom mic on it, which is great if you're wearing the spacesuits, and actually works outside the mask. It works better inside some of the masks, but some of them, they lose their fit test. So we're doing a formal fit testing analysis. Business cases are clearly very important. Some of the off-the-shelf solutions are around 10,000 for a set. This is likely to be a lot more than that unless it's produced in large amounts. We're also extending our use cases to robotic surgery and dentistry, and also looking at it with regard to education. Importantly, all these published studies on theatre education don't consider hearing impaired staff, so we're also going to look at hearing impaired staff. One of the first times we used this, I realised that the registrar across from me could only hear in one ear, and that is clearly very important. So we are going to look at that as well. So what we've learned from all this is, first of all, there is a huge amount of operating theatre noise anyway, and we don't have discipline as surgeons, certainly not the same discipline we have in aeroplanes. And we need to take that away from the pandemic, that actually we do need to be more disciplined about it. We need to introduce a kind of particularly quiet zone around the induction. When we first rolled the radio system out, the first time we used it without any training, everybody suddenly behaved. Everybody suddenly weren't talking about the dog or what they'd eaten the night before. So actually there's an instinctive discipline that comes with wearing this equipment. We may indeed be mandated if in the future we're all asked to record everything that's happening in operating theatre, as they do, for example, for heart cases at GOS. So you don't need the same solution as us, but you do need to have some solution, or at the very least, you should be introducing some discipline. And way beyond COVID, we think this is going to be important. Thank you.
Thanks very much, Martin. Thank you for educating us about noise levels in operating theatres. Fascinating. So we are a little conscious of the time. Our next speaker, Matt Gardner, is going to talk to us a little bit about what we've learned about learning. Matt's a plastic surgeon, and Matt's going to speak, and then we will take some questions with the aim to finish at 7:10. Thanks, Matt.
Thank you very much. Next slide, please. I'll keep this short and sweet. So we've all become very au fait with online learning and webinars, and along with the RCS group, we felt that developing some new online resources would be very beneficial, not only to surgeons, but also the wider surgical team and beyond. We've developed a collaboration with FutureLearn, which is run by the Open University, and the teaching and learning will be over 4 weeks. It'll be online and available to anyone to sign up. And the aim is that these collaborative online resources will be available to everyone. More recently, the NIHR have prioritized e-learning and advertised for calls to develop up to 10 modules to meet the needs of a broad range of healthcare professionals. And so the RCS Education Department, led by Louise Goldring and Liz Brookfield, is developing an application, and we hope to take some of the topics that we cover in the FutureLearn course and go into more depth. So some of the modules that we're thinking about will cover developing a good research question, involving patients, in engaging industry, the pros and cons of pilot studies, big data, using networks, building networks, and perhaps how to be a good collaborator. So we're very open to suggestions, and we'd love to have engagement and ideas to see whether we're meeting the needs of those viewing today. We'd be very grateful if you get in touch with Liz at the email address below, and I'm also very happy to be contacted at any time. We hope that the FutureLearn course will be available irrespective of the outcome of the NIHR call later this year. Thank you very much.
Great, Matt, and thank you very much. And really nice example of how we brought the research department and the learning department together, thanks to Matt's efforts and those of others. So that leads us on to the questions and the discussion that's going to be chaired by Professor Friend. Just to thank all the speakers from me.
Yes, again, thank you very much for really excellent and interesting and very different presentations. We don't have a great deal of time. In fact, we've agreed to run over by 10 minutes because we were a little late starting. So I hope that's all right with everyone. That gives us 8 minutes. Let's just, there are a few good questions which have been sent in on the chat, but let's just start off with a general question, which is about scale. And I'm going to ask both James and Hutch to address this issue about how you get these massive projects off the ground. I mean, James, you're talking about projects with 15,000 investigators, co-authors, and so on. I can't imagine where you begin to get that plane off the runway.
James, why don't you address that?
Of course, yeah. I'll perhaps comment first. Thanks, Professor Friend. So I think the first thing is that it addresses a priority topic which everyone can get behind. And in our sort of global surgery unit, we run these prioritization cycles to try and find these really high impact global topics. And of course, COVID was at the tip of everyone's tongue. So I think that was a really important part of the driving engine. And the second thing to say is it sort of grows upon previous experience from these collaborative networks. And there was nothing new that was done as such. It was just using the same infrastructure and methods and efficiencies that we've learned over the last 10 years or so of doing these study types. So it grows on what's through the surgical trial centres and trainee collaboratives. I think the final thing is that we have developed these processes now using REDCap and R, which is statistical programming software, to automate a number of the more harrowing tasks. I remember when we ran the RIF study, which was a right foster pain study in the UK, we had to sort of upload each individual person into data access groups, and it was miserable. It took us all about 24 hours sitting at the computer, and now that we can automate all of these processes and authorship lists and things, so we'd love to share that experience. And Kenny McLean in Edinburgh has done an amazing job of automating some of these processes with you and Harrison and the team up there.
Maybe I should just add to James. I think what's been amazing is how everybody's worked together. Felicity alluded to this earlier, and how the group gelled together, and we've met people from specialties that we haven't met before. So I think there's been a huge collaborative effort, both surgeons but other healthcare professionals. Martin's talked about that, and how we've engaged with the journals, the media. It's been a whole different experience to make things happen very rapidly.
There's a question in the chat which I would like to ask, and that is serendipitous or accidental experiments. Any evidence that things we've discovered that we simply weren't expecting? And that's a question to anyone to answer, I think. So what the example that's put up here is the non-surgical treatment of appendicitis. Who would like to address that?
No, well, I mean, there's been two studies. You address that.
Actually, I just wanted to make a general comment about using routine health data. And when a natural experiment like COVID does happen, we then have two types of data. One, how COVID affects our patients. Two, how disruptions to our normal protocols that maybe would not be ethical to formally study. We have a responsibility, I think, to study the impact of delayed appendicectomy, delayed cleft lip repair, which we could never get ethical approval to do. We never have equipoise to do. And I think that's a very different model to the formal RCT, for which sadly, it is a lot easier to get funding than taking opportunistic routine healthcare data. And I think we need to make more of opportunistic routine healthcare data. So that's a more general comment, but yeah.
So Felicity, you talked at the beginning of your talk about questionnaire fatigue, or what words, survey fatigue you called it. How big a problem is that in the mass data gathering exercises, and how do you deal with it?
This is an anecdotal comment, but certainly at the start of the pandemic, I think a lot of us were getting all sorts of surveys, often covering similar things. And one thing that I think the group may have prevented was a degree of duplication of efforts. There was a much more coordinated approach to things. So one approach would be having some sort of a joined up national approach to things, or even an international joined up approach to things. And I think being sensitive about what questions are asked. Certainly, personally, we merged two potential cleft COVID questionnaires, but I'm sure there are others who have got similar examples of good practice.
Yeah. Thank you. There's a question about how to integrate different types of different grades of staff, in particular SAS doctors, and how's that achieved? Jasmine, is that something you could address?
Thank you, Prof. Friend. I was answering specifically about the SAFE question. Within that study, we had, I think, 600 doctors, and part of those were surgeons of different grades, so I can't answer specifically how many SAS surgeons reported burnout, anxiety, and other mental well-being problems. In terms of encouraging SAS surgeons to partake more in research, if that was the question, I am not sure exactly how we can go about that. Maybe the Royal College could introduce some initiatives to try and reach out and involve people who maybe are not necessarily within teaching university hospitals. So, maybe we could have an initiative to reach out academically to the DGHs and more remote centres. But I don't have to think about it. We'd welcome everybody to our study.
Martin.
Yeah, no, I've really welcomed the question, because actually it's not something that we've considered at all so far in the NIHR incubator. You know, the idea is to try and increase research awareness, development and careers for all theatre staff. But I'm really glad it's been brought up, because it's not something we've looked at all. And You know, I'd love to engage further as to how we can appropriately bring the SAS community into the research that's being done in the collaboratives and beyond.
Thank you very much, Martin and Jasmine. I fear that we are coming to the end of our time. There are other questions. Apologies to people who've posted questions that we've not got round to, but it is just 7:10 and our instructions are we finish at 7:10. So I'm very happy to thank the speakers for really excellent and stimulating presentations, to thank the organisers of this fantastic COVID collaborative, which is a really brilliant initiative and which is going to go on to deliver more and more worthwhile data. And it's a real model for how you can make something important happen when the opportunity comes, if you're minded to do so. And thank you also very much to all the staff who've made this happen from the College of Surgeons. And last, of course, not least, thank you to the 100 and however many people it is who have attended, which is much appreciated. Thank you.
Bye, everyone.
Bye, everyone.
Bye.